In this class, we'll try to learn about parathyroid gland. Before that, we'll try to learn about what are the different hormones that are secreted from parathyroid gland. Parathormone is secreted from parathyroid gland. Calcitonin is secreted from parafollicular cells of thyroid gland, and cholecalciferol. Coming to calcitonin, calcitonin is secreted from parafollicular cells, that is C cells of thyroid gland. The parafollicular cells develop from ultimobranchial bodies, a pair of gland that develop from the fifth branchial pouch. Calcitonin is a polypeptide hormone containing 32 amino acids. The molecular weight is around 3500. The calcitonin gene that transcribes mRNA to form calcitonin is processed to form a different mRNA in the nervous system where it forms calcitonin gene related peptides, that is CGRPs. CGRP is a potent vasodilator. The major stimulus for calcitonin secretion is the rise in the plasma calcium level. Above the concentration of 9 milligrams of plasma calcium, the secretion of calcium becomes directly proportional to that of calcium concentration. The other stimuli like beta receptor agonist, dopamine, GI hormones like CCK, glucagons, gastrin, secretin, and estrogen stimulate the calcitonin secretion. Gastrin is a strong stimulus for calcitonin release. The concentration of calcitonin in plasma is around 10 to 20 picograms per ml. The concentration increases almost tenfold in hypercalcemia. The hormone is degraded in liver. The half-life of calcitonin is around 5 to 10 minutes. So these are the physiological actions of calcitonin. So decrease in the calcium, it stimulates the calcitonin secretion. The calcitonin acts on the kidney and the bone. Over the kidney, it decreases the phosphate and calcium reabsorption, leads to phosphaturia and calciuria. So that decreases plasma phosphate and plasma calcium. Where on the bone, it increases the resorption and decreases the calcium released into plasma. So it leads to reduced plasma calcium. Paget's disease. In this disease, increased osteoclastic activity of unknown etiology results in localized regions of the bone reabsorption followed by a compensatory osteoblastic activity causing patchy new bone formation. Thus, pagetic bones are structurally disorganized and susceptible to deformities. X-ray picture shows uh, areas of increased density and resorptive cavities. Though most of the patients are initially asymptomatic, bone deformities resulting in compressive neuropathy and subsequent neuromuscular dysfunctions are not uncommon. The disease is treated by daily injections of calcitonin. Biphosphonates like etindronate and palmindronate are more useful in preventing bone resorption. Vitamin D decreases plasma calcium level by increasing calcium absorption from GI tract, calcium reabsorption from the kidney, and mobilization of the calcium from the bone. It has a similar effects on phosphate. So these are the steps of synthesis of vitamin D. 7D hydrocholesterol gets converted into cholecalciferol under the influence of UV light. Then it gets converted into 25 hydroxycholecalciferol. In kidney, it gets converted into 125 uh, dehydroxycholecalciferol, which is an active form of vitamin D3. There are vitamin D receptors in GIT, bone, and kidney. The mechanism of vitamin D action is like that of steroid hormones. It binds with the nuclear receptors and nucleus and induces receptor phosphorylation, which targets DNA molecules. The major product of vitamin D action is the increase in the intracellular calcium binding protein called calbindin. So these are the physiological actions of vitamin D3. It is produced in the skin and it is going to act on kidney, intestine, and the bone. For the kidney, it increases the phosphate reabsorption and increase calcium uh, re- reabsorption, and it is going to decrease the phosphate excretion and increase loss of calcium in the urine. So it increases the plasma phosphate levels. Whereas in the intestine, it increases phosphate absorption, increase the calcium absorption from the intestine. So that leads to increased plasma calcium and increased plasma phosphate levels. Over the bone, it increases the osteoblastic activity and also increases bone resorption, mobilizes calcium into plasma. So it leads to increased plasma calcium levels. Vitamin D deficiency leads to rickets and osteomalacia. Deficiency of vitamin D causes rickets in children and osteomalacia in adults. Some of the causes for vitamin D deficiency are inadequate intake, lack of exposure to sunlight, chronic liver disease, chronic renal disease, hypoparathyroidism, anticonvulsants like phenobarbital, vitamin D receptor deficiency, vitamin D dependent rickets, that is hereditary deficiency of 1 alpha hydroxylase, and autosomal recessive disorder. The disease is characterized by inadequate mineralization of the bone matrix. Both trabecular and cortical bones are involved. In both adult and children, excess unmineralized osteoid accumulates in the bone. The concentration of calcium and phosphate is significantly low. Bone strength is reduced and therefore they distort in response to mechanical load. In children, decreased mineralization diminishes the bone rigidity that results in bowing of the long bones of lower limbs and ricketic chest. The epiphyseal growth centers are affected by defective mineralization of bone. In adults, longitudinal growth of long bone is already completed. In adults, bowing of the bones does not occur. However, due to increased unmineralized osteoid content, bone pain, vertebral collapse, and fractures are common. Treatment is vitamin D supplementation and it should be started at the earliest. Sometimes vitamin D excess usually occurs due to the excess intake of vitamin D. It causes hypercalcemia, hypercalciuria, and kidney stones. Increased bone reabsorption is not uncommon. Hyperphosphatemia is also present. Coming to the parathyroid gland secretes a hormone called as parathyroid hormone and or parathormone. The parathormone is a major regulator of calcium and phosphate metabolism. The parathormone increases the plasma calcium and decreases plasma phosphate levels. In human beings, there are four parathyroid glands present in the anterior aspect of the neck, embedded posteriorly at four poles in the thyroid tissue. The thyroid glands develop about 10th week of pregnancy and from the third and fourth branchial pouches. The total weight of four glands is around 200 milligrams, each gland weighing approximately around 50 milligrams. Parathyroid glands derive blood supply from the thyroid arteries. So this is the structure which is showing in the uh, location of the parathyroid glands. Note the four uh, tiny glands, superior and inferior parathyroid, and they receive blood supply from the posterior branch of the superior thyroid artery and inferior uh, and uh, and branch of inferior thyroid artery. So these are the different types of cell that we see in the parathyroid gland. They are called as chief cells and oxyphil cells. Chief cells and oxyphil cells. Like other peptide hormones, parathormone is synthesized from larger precursor molecule called as pre-pro-PTH that contains 115 amino acids. The leader sequence containing 25 amino acids is removed from amino terminal in the endoplasmic reticulum to form pro-PTH, which contains 90 amino acids. In the Golgi apparatus, other 6 amino acids are removed from amino terminal from the PTH containing 85 amino acids. PTH is then packaged and stored in the granules of chief cells. So this is how parathyroid hormone is secretion is regulated. So as the plasma ionic calcium level increases, the rate of PTH secretion is going to reduce. So note that from 3 milligrams to 6 milligram percent, the relationship is linear. So this is the mechanism action of parathormone. Okay, so it is going to act on the uh, steroid steroid-like receptors on the nuclear receptors. It is going to sorry, it acts on the cell membrane on the parathormone receptors, and it is going to increase the cyclic AMP and IP3 levels and increase the release of calcium from endoplasmic reticulum. So these are the effect of parathormone, that is reduce calcium levels in the plasma. It leads to increase in the formation of the PTH. Okay, so that is going to act on the kidney and the bone. Or the kidney, it decreases the phosphate reabsorption, increases the calcium reabsorption, and also increases the formation of 125 dihydroxycholecalciferol. Okay. And so this going to act on the GI to increase calcium absorption, so that ultimately leads increase in the plasma calcium and decrease in the plasma phosphate levels. Whereas over the bone, it increases the reabsorption and calcium is released into the plasma to increase the plasma calcium levels. Hyperparathyroidism. Hyperparathyroidism is or PTH excess is divided into two main categories: the primary hyperparathyroidism and secondary hyperparathyroidism. Primary hyper primary parathyroidism hyperparathyroidism occurs due to the tumor of parathyroid glands, such as parathyroid adenoma that secretes excess of PTH. It may be part of multiple endocrine neoplasia, that is MEN syndrome. It is common in men type 1. The disease is characterized by hypercalcemia, hypophosphatemia, demineralization of the bone, hypercalciuria, and renal stone formation. In chronic effect of parathyroid excess results in bone disease called as osteitis fibrosa. So there will be a features of osteopenia and fracture. In this disease, the bone marrow is fibrosed and bone resorption exceeds the bone formation. Secondary hyperparathyroidism occurs in chronic renal diseases and rickets. In these diseases, chronic hypocalcemia causes increased secretion of PTH. So this results in secondary hypertrophy of parathyroid glands. Neonatal primary hyperparathyroidism also has been described that occurs due to a genetic defect. In malignancy, a hypercalcemia occurs in malignancies. So this is mainly due to the bone metastasis by cancer cell that causes local osteolysis, which results in hypercalcemia. Hypercalcemia also occurs in malignancy due to the ectopic secretion of parathormone or PTH related proteins. Usually it is seen in the cancers of breast, kidney, lungs, ovary, and skin. Hypoparathyroidism. Hypoparathyroidism is rarely seen as a disease of parathyroid gland. Rather, a common entity is a pseudo hypoparathyroidism, which symptoms of PTH deficiency are observed in the presence of normal PTH level in the plasma. There are two types of pseudo hypoparathyroidism: a congenital variety in which PTH does not increase the cytosolic cyclic AMP and IP3 formation in the target cells due to receptor defect. Another variety is in which cyclic AMP is synthesis by PTH remains normal, but PTH fails to produce phosphaturia effect. Phosphaturic effect. In hypoparathyroidism, hypocalcemia and increased bone density are main features. Hypocalcemic tetany. Hyposecretion of parathyroid rather common following thyroid surgery in which parathyroid glands are usually removed by mistake along with the thyroid gland. So this causes severe hypoparathyroidism that leads to acute hypocalcemic tetany. Features of the tetany are Chopstick sign. This is a quick contraction of the facial muscles on the same side by tapping over the facial nerve at the angle of jaw. Trocheus sign is a spasm of the muscles of the upper extremity that causes flexion of the wrist and thumb, that is the flexion at metacarpophalangeal joints with extension of the fingers, that is extension of interphalangeal joints. Carpus pedal spasm is also a spasm of muscles at the wrist joints, that is carpal spasm. The changes at wrist and ankle joints together they called as carpal pedal spasm. So, laryngospasm can occur in hypocalcemic tetany. Usually, patients die due to the hypoxia that occurs because of the laryngospasm. The muscles of larynx contract and occlude the laryngeal passage. Hypocalcemia is significantly seen and hyperphosphatemia. The treatment of hypocalcemic tetany includes immediate administration of ionized calcium and parathormone. So this is the diagram showing carpal pedal spasm. So this is all about the parathyroid gland in brief. Thank you.